Assalamualaikum and good afternoon. I'm going to talk a little bit about juvenile arthritis. This is an arthritis that is seen in children 16 years or less of unknown etiology and that lasts for at least 6 weeks. It is important to recognize that this is different from adult arthritis. It presents differently. Children will not express pain as easily as adults do. Clinically, it is more difficult to elicit swelling in children, and normally young kids have a greater range of motion of the joints, so you may not pick up limitation of movement that easily. It is fairly rare, occurring in less than 1 in 1,000, but with a Pakistani population touching I think 180 million now, and about 40% is 14 years and less, that's a significant number in Pakistan. Various classifications have been floated. Now the ILR classification is one that is universally accepted, which divides this into about 6 subgroups. Out of these, the systemics and the seropositive polyarticular have significant morbidity attached to them. In the Western data, the polyarticular, which is 4 joints or less, seem to have the greatest prevalence. Almost 50% of children fall under this group, and they also have the best prognosis. About 50% remit within a few months to a year. Only 50% go on to have arthritis in adulthood. But the subset, which is seropositive polyarticular, actually seen in only about 10% there, has the worst prognosis. We did a little pilot study on about 91 children that came to our clinic, and we found that over 40% of our kids actually were seropositive polyarticular. So it's important to pick them up quickly because they are the ones that are going to have long-term morbidities. Systemic, associated with fevers and rashes. The fever is very specifically quotidian. That is that it has a spiking nature daily, and it will go beyond below the baseline as well. So the child is relatively well in between the fever, and the rash comes and goes with the fever. Typically, young girl, less than 6 years, 4 or less joints, as I mentioned. One complication that occurs in these children is uveitis. Up to 20% can have uveitis, and that is a serious cause of blindness in children. Polyarticular, psoriatic arthritis. This is a patient, as you can perhaps make out, that there is dactylitis. I don't know if the point is working. Yeah. This one, and over here as well. And this girl had a grandmother who had psoriasis. ERA, I think Dr. Mara Bacha gave an absolutely fabulous talk on spondyloarthropathies. ERA is actually the childhood counterpart of AS, and similar presentation with inflammatory back pain with probable history of enthesitis, may have HLA-B27 positive, occurs more commonly in male children over 6 years. Before diagnosing GI, please don't forget common things like infections, immune-mediated conditions that can occur in children. Very important, childhood malignancies. Specifically 2 things, leukemias, specifically acute lymphoblastic leukemia and neuroblastomas. These kids will be very sick. They can come in with joint pains, but they will have fever that's unremitting, maybe a history of weight loss. But specifically more important is that they have persistent pain, pain that wakes them up at night, which does not usually occur with juvenile arthritis. What is the prognosis? Why do we worry about it? Children who have low limb involvement would have leg limb discrepancies and later on growth abnormalities and gait problems. Anterior uveitis, as I mentioned earlier, more commonly seen in oligoarthritis. About 50% of the polyarticular remit, 50% go into adulthood. But for polyarticular and systemics, up to 70% will have significant arthritis as adults as well. Please remember, radiographic joint damage may be delayed up to 5 years in every day, but occurs within 2 years in polyarticular and systemic, so they need to be picked up earlier. long-term disability seen in up to 40% of children and up to 2% mortality rate, especially in the systemic juvenile arthritis. How do you manage them? Symptomatically, with non-steroidals, steroids, sometimes initially, DMRs, is a whole list of them including biologics, and an adjunct of resting and dynamic sprinting is needed in small children with physical rehab. Very important, please switch NSAID if you response within 3 weeks, and if it's not working within 3 months, think of something else. NSAIDs will not delay or prevent joint damage. Unlike in AS, it's more like rheumatoid, it will not prevent joint damage. So don't stick with just giving an anti-inflammatory in children. Steroids systemically may have to be used in polyarticular systemic disease and as local drops for chronic uveitis. They are used as intra-articular agents, particularly in post-articular where they may be all that you need.